and welcome to Psyched for Sanity. I am one of your hosts, Dr. Brindle Doss, a licensed clinical psychologist specializing in forensic psychology, assessment, child treatment, geriatric psychology, and the treatment of trauma.
I'm Dr. Tara McKelvey Parker. I'm also a clinical psychologist. I specialize in assessing and treating complex trauma and attachment wounds from childhood. And I was a little bit of a rebel when I was going to say a teen, but also a child. I had a rebellious streak. And one evening, I think I was probably like 16 at this point, and my mom was like, "You are not allowed to leave this house." There was probably like some ridiculous reason, but I was like, I'm going to leave the house. I called one of my friends who I'm still very close friends with, and she came to pick me up and helped like sneak me out of the house. We got in the car, and I thought we were good. We, started leaving and turned down this busy street the wrong way. My whole entire life flashed before my eyes, and I was pretty sure that it was a punishment for my sins.
And your sins.
Because I snuck out of that house. I say I was a rebel. I really wasn't. I was like a goody two shoes, but I had like this like little rebellious streak kind of but that was scary for me. And I was like, oh my God, I'm going to get in trouble. And then we turned the wrong way down the street. And I was like, oh my gosh, I almost died because I disobeyed.
I love that fun fact. That is a fun fact.
Yeah.
I fear that my fact is, again, a combination of probably funny, but maybe sad.
God.
When I was a similar age, maybe a little older, like 17, 18, I worked in a grocery store. And the kind of grocery store they had long registers at the ends, like the belts were behind.
Oh, yeah.
So a colleague of mine discovered that if he jumped out from behind the registers and surprised me, that I would fall down and faint like a sheep, but not really faint, but just fall down.
You are like
and lay there until it was safe, like one of those goats.
You do that. I remember that about
you. Have I done that with you?
Yes, you do that all the time. Like when you were a postdoc, like noise, you were so scared. Like you were very easily startled in that way.
So yes, and I think I've gotten mostly over it, but I still be like, but I don't fall like I used to. But I used to fall and just lay there. I wasn't unconscious. I would just lay there.
It's like such a trauma response.
It's 100% a trauma response.
Like that's like classic like PTSD symptom. Well, okay, so would you ever tell a patient that story?
I think I just did.
Oh yeah. Well, okay, yes. We started a podcast.
Yeah.
So obviously we're like somewhat okay with self-disclosure.
Yeah. Yes, we are.
Right? And so, but self-disclosure in therapy, like as a therapist, it's interesting. I think it depends. Using self-disclosure depends on a lot of things.
Yes.
And so,
do you remember in school though?
Oh,
what were we taught in school?
Do not ever tell anyone anything about you ever.
Right, because it's bad.
Boundaries,
bad, wrong.
When you're like a young clinician, like boundaries is like you're so scared to do
you're scared to do anything.
Like take risks when you're be a real person. Not for everyone, but I do.
A lot of people.
I feel like that's been my experience, and a lot of at Dallas Therapy Alliance where I work, we train postdocs, and I feel like that's pretty common. Like you just are kind of scared to.
Yeah, you're scared to like share about yourself, and therapy is a weird relationship where, people come to us and come to clinicians, psychologists, therapists, whatnot, and they pour out their hearts and souls. But the whole mindset from school was that we were taught is that you don't share anything about yourself. And that's a little complex and challenging, I think, because how I was trained in school with self-disclosure is not how I operate today.
Yeah.
What do you think? Like, would you say the same?
I think that's true. Like when I think, again, thinking about the postdocs.
Yeah.
And how scared they are to take risks and share information, the people I train. I remember being that way when I first started out because there's a lot more fear, I think, out there, and when you're treating people and just wanting to kind of like maintain safety and boundaries and like what you were taught in school.
Right.
But as I've gotten more seasoned in what I do, I definitely self-disclose more.
Sure, same.
But I think self-disclosure means different things. I think you have to really keep in mind the purpose of why you're self-disclosing.
So critical.
if you're still making the patient the priority, like I think those things are, really important. And I think
Yeah.
the setting, like where you are, what's appropriate, what boundaries are already kind of more inherent in that setting.
Sure, and also can be even considering where the person is in treatment.
Yeah. Yeah. Yes. Yes. I think so. Yes, that's true. Like, um, at least what Pete Walker says, who I think I've mentioned here a lot because I love him and he's like, a CPTSD guru. He talks about for people with complex trauma how it's, um, pretty important to not self disclose a lot at the beginning. It's
At the
really more
beginning.
patient focused. The boundaries being more in place is actually safer
Sure.
for the patient with trauma. But as treatment progresses and the relationship develops and it becomes um, closer, more connected, whatever, yeah, it's like more reciprocal. There may be a little bit more sharing involved.
Yeah, and I think that self-disclosure also like can change from client to client.
Mhm.
And I think it's important, I think, like sometimes some clients are less comfortable with their therapist sharing about themselves,
Mhm.
even if it is
Yeah,
treatment relevant and even if it is
yeah,
in
totally.
serving the purpose of the relationship.
And certain therapists too. I certainly know even seasoned therapists who there are some modalities of treatment where self disclosure is more relevant, important. Um, but even so, so some therapists choose modalities where self disclosure is not really a part of the treatment, or they're
Right.
just less comfortable because of their own reasons, and so that's totally
Yeah,
important and valid. I know that you've worked in a lot of
I have.
settings across your career so far. And I imagine that self disclosure, like what you disclose and when, has varied. I would assume.
It's varied widely, and I think
Mhm.
that's important to know. For example, I used to work in a federal prison, and part of the training that's very different than almost any other setting I can think of is that at a federal prison they teach you you're an officer first and then a psychologist, which is very very bizarre because
Mm.
psychologists are trained even different within different modalities to be warm and empathetic and responsive
Yeah.
and to develop relationships, but in the prison system and in most prison systems that's not necessarily the first thing that you're trained in that setting.
Mm.
um, in the federal prison, for example, the people I worked with, they did not know my first name. And it was considered a lot of the times a real taboo thing and a risk for any
Mm.
person that's currently incarcerated to know my first name.
That's interesting.
Mm-hmm. And to know, I know some clinicians that work in that setting that have no pictures of any family or friends in their office. Most of them don't. Some don't, even if they have wedding rings, they don't wear the wedding ring.
Okay. So boundaries are
Stream.
much more important and part of the system. And so that's going to obviously color
So
what,
much part of the system because it can come back to safety of the institution.
yeah.
And that is the first thing, the first priority for every officer is the
Mm.
safety of the
Of the
institution.
institution. Wow, that is really
It's
interesting.
very different versus one of my jobs now is I work in long term care settings or nursing homes. And when you work in a nursing home, when you go to see a patient, they don't come to an office. You literally walk into their physical space,
Like, yeah, or
like what you
building.
would call their home. Like
Yeah.
you walk into their room when they're got pictures of the
Mhm.
grandkids and all their things, and their whole life is in front of them. And so you're coming in their house. And so they want to know about you.
Yeah.
They want to know your kids' names, their ages. They want to see pictures of your kids, which can be a challenge
Depending on, yeah,
depending
I'm
on
sure
person,
depending on the clinician,
depending on
there's
the clinician's comfort level.
different
But
ways of handling that or different.
where I have worked and the different settings I've worked at, the prison system and nursing homes, even in outpatient settings, in each different setting, I've had to adapt and figure out what am I comfortable with in terms of self disclosure, what is appropriate for this setting,
Mm-hmm.
and what do my patients need. And that changes for every setting I've worked in.
Depending. And so, when you're talking about self disclosure, I think you're being really specific about personal information,
Yes,
which is one kind of self
there's
disclosure.
tons of types though.
Yeah, yes. And I would say, like, I'm a person who practices a type of treatment
Yeah.
where self disclosure is actually really
I
important
was
and
going
like
to ask
part
about
of
that.
the treatment.
Can you talk more about like what type of treatments do they have that are really focused on using that as a tool almost?
Yeah. So I would say I'm really pretty interpersonal and modern, or maybe more modern relational in the
Okay.
way
Yeah.
that I treat patients. So, like, I'm always thinking about the relationship and what kinds of like childhood wounds my patient has. And so, like, are they having a hard time being angry and setting boundaries?
Yeah.
Well, then I'm going to try to create a relationship where they feel safe enough to get angry and set boundaries with me.
Yes.
And so I'm always trying to create a relationship with that information in mind. And so it's really important to me and part of the treatment actually to share how I feel about the relationship, about my patients. Like, they can ask me what I'm thinking about them and how I feel about them.
And you respond with
Um,
authenticity.
yeah, absolutely. That's the entire treatment. It's like building a healthy,
Yeah.
secure attachment with my patients, and that's like, I think you have to be able to do that, but it is for the patient,
Yeah.
and it's in the context of the patient therapist relationship, and it's my goal. Like, I'm trying to
Yeah.
create health and safety for my patients and relationship. Um, but I also do think like just personal stuff to share is really important too. I don't know if you remember learning in school, like there's the therapeutic relationship and then there's
Uh-huh.
the real relationship.
Yeah.
Do you remember that?
Yeah, I do.
Like how important it is to seem like human and real.
I think that's a critical thing. And I think it kind of can go against some of certain types of modalities would not have that. In some
Hmm.
traditional stances of therapy, there's a power differential between the therapist and the patient and the
Hmm.
client.
Yeah, that's true.
And so I think that's a different side of that. But I think that, disclosing, your therapist disclosing what they're feeling or thinking can be really helpful and transformative.
Hmm.
Personally, that's my
Hmm.
opinion. I tend
Hmm.
to lean towards your side.
Hmm.
But I think as a clinician, I always have to be guided by if I'm going to tell any type of story or anecdote or any kind of divulgence whatsoever, even an honest reaction, how does this serve the patient and how does this serve the relationship?
Yeah. Yes, that's key. Like, I'm, not going to just sort of willy-nilly share things.
No.
If I find myself doing that,
Oof.
right? Like, I'm questioning what's going on in the relationship.
Right.
Right? Like, what's happening here that's making, because I do feel like a little bit of chit-chat in the hallway or like the first 5 minutes of session. I do have patients who are like curious about me and want to know things, and I'm totally fine with a few
Right.
few minutes of chit-chat at the beginning.
Have you seen those
Um,
social, like those, like either videos or like memes or things like that? Like what I think my therapist is thinking. There's
yeah.
a whole like smorgasbord of like stuff out there where patients try to figure out or understand.
Well, and I think because it's the power imbalance. Like,
Yes.
it's scary to be in a relationship where you are doing most of the sharing. All of it.
Right.
Honestly, like, really, even, again, even in the type of treatment I do, I'm not talking a lot about myself and my own reactions. It's
No.
much more exploratory of the patient, but it's like so vulnerable and it's scary. And
Right.
so I do think there's a place for um Pete Walker coined the term like vulnerable self disclosure. Like, sometimes I think one of the main reasons why I usually self disclose in the
Yeah.
moment, if I share something personal like during treatment,
Okay.
is because I want to reduce my patient's shame. I want them to
Powerful.
feel like they are not alone in some of the stuff they're struggling with because
Right.
I've been there,
Yeah.
right? And I have felt that shame. And like, isn't like Brene Brown that says like the number one reducer of shame is to not feel alone in it, to feel connected to a person who is also, like effed up or who has been depressed or has had a panic attack or has like whatever. Like,
Yeah.
so, but it's intentional.
It
It's
has to be really
intentional for
intentional.
that purpose.
I think it has to be intentional. And, I was thinking about what you were saying and that it's really, really powerful. And I think you and I, as clinicians, we use self disclosure maybe more. I think we're more on the disclosing side
Yeah, for sure.
than others.
Yeah, maybe. Yeah, probably.
And I think that each to his own,
Mm-hmm.
as
Mm-hmm.
far as clinicians go and
Mm-hmm.
psychologists, therapists, what have you. But one thing that I really thought was really such a great piece as to why self disclosure can, in my opinion, which I share with you, so important and valuable is there's not even for people without complex trauma or even single incident trauma, it's hard to find a place in a relationship that allows for safe anger expression
Mhm.
and repair or like moving through a relational conflict.
Yeah,
That is
relational
so,
conflict.
even in healthy systems, that can be really, really hard.
Definitely, for sure. I think another one, another like helpful use of self disclosure is for helping patients mentalize more. Like I mentioned, I think, I mean, I'm in my own therapy and I certainly have had moments where I'm like, she absolutely is thinking I'm super pathetic, like just feeling like,
Right.
like under the microscope and super
Yeah.
ashamed and vulnerable, or like, just like anxious about how I'm doing, or like, am I a good enough patient? And so I do think sometimes when my patients voice those concerns,
Yeah.
it's really helpful for me to be like, hey, do you know what I'm really thinking right now? Right. So they like can start to consider new options when they're
Sure.
feeling ashamed or anxious.
Right.
That story or that narrative I tell myself is probably not true. She's probably not thinking those things about me.
Right.
And then we can talk about it and they can kind of know it's never any of that. I am never thinking those things about my patients. Most of the time, I'm like relating or like thinking about how I can help them feel better.
Or
Usually,
I've experienced pride.
yeah. Oh,
I've,
for
as a
sure.
clinician, when
Yeah, yeah,
someone's,
yeah.
oh, you probably think I'm a mess. I'm like, no, I'm actually really, really proud of you. And I'm feeling intense and emotional because you're doing such hard work.
Yeah.
And I'm just really
It's usually love. Yeah.
appreciative of being able to be with them
Hmm.
during that hard, hard thing.
Yeah. I mean, it's not always like roses and sunshine. I
No.
mean, certainly I've had like frustration with patients and,
And
um,
patients probably have been frustrated with us.
yeah, I am certain that's true. And I'm always like, it's okay. You can tell me. But it is really hard for patients to be
Right.
angry with us. That for it's
Well, I
to
think
express it.
because that's why I brought that up to you, because I think it's so critical in having that safe disclosing relationship that remains patient focused
Hmm.
is paramount. So, as we're trying to wrap up today, like,
Hmm.
what are you taking away, and what do you need?
Well, I was thinking about my own therapy
Okay.
actually, and like how maybe I could be brave and I could voice some of these like things that I sometimes think
Yeah.
she's thinking. It's really hard to be open and honest about that. And
So
then to
hard.
have that sort of like moment of
Yeah.
clarity from your therapist or connection or whatever exploration. I was thinking, man, I should do that more. I'm talking about that in here. And it's really hard to do on the other side. So I really get it. Like being able to voice those things. So I'm like, oh, that could be good um, for me. I think that could help my own therapy.
Yeah. And what I'm taking away and what I'm like struck with is like how just this kind of the same is like how hard it is.
Mm-hmm.
How hard it is to go in and be vulnerable and authentic and like raw, and how much, how difficult that is in exposing, and how I think that just appreciation for patients that do the work with us,
Yeah.
with or without the disclosure,
Yeah. Yeah.
you know?
Yeah. Even though I'm a little biased and I think it's helpful in a healthy,
I'm with you in
intentional,
that bias, friend.
grounded
I am
way
with
where
you
it's
there.
like,
You
yeah.
know, I used to tell patients, you can ask me any question. I might not answer some
Hmm.
questions, and I can explain to you why. But I have two cats. My favorite color is blue, and I am not a fan of the beach. I used to do that at the beginning. Kind of an awkward
Yeah.
icebreaker to kind
Yeah.
of
Of
like help
course.
them,
Yeah. Yeah. I think that's why just building relationships is really,
because the
I think,
relationship
just
is the
important.
key and such a critical a change element.
Yeah.
And it's hard to get to know someone and feel safe in
Yeah,
a
to any
way.
kind of therapy relationship and modality, all of
Right.
that is so just I think important.
Without that developing relationship. So I'm
That's
just
why we're doing
appreciative.
this podcast, because we appreciate you guys,
We do.
and love that you're watching us, and
We are
hope
very
you find it
appreciative.
helpful.
Yeah. Yeah. And if you've ever had a therapist that like just maybe disclosed too much, that you were uncomfortable, leave us a comment if you want to. You don't have to.
Hmm. Hmm.
But if you also like maybe, you wish your clinician was more sharing, that's another possibility. But,
Hmm.
I think to each their own, but you and I kind of are in the same boat on this.
Yeah, so cool. We love sharing.
I like being in the same boat as you.
Aw, me too. We'll row together. It's cute.
This podcast is intended for informational and educational purposes only and is not a substitute for therapy, diagnosis, or any kind of professional mental health treatment. We hope that we can share with you our experience authentically and genuinely, and we hope that occasionally we'll make you laugh. Maybe you can relate to our quest and how we're psyched for sanity. The content we share is our personal opinions and insights. They are not clinical insights to anyone, and they don't represent or reflect any entity that we work and or have worked for in the past. But if listening to this podcast has made you think, we really encourage you to seek out a mental health professional in your area.